and UC Irvine, California, USA. Dr. Bhangoo earned his medical degree from GGC Medical College in India. He had the fellowship and residency in Maimonides Children's Hospital of Brooklyn, New York. And now he's working as an assistant professor of pediatrics at the Sunny Down State Medical Center, New York, before moving to California. His main research interests are about growth disorders, Noonan syndrome, achondroplasia, glucocorticoid resistance syndromes, insulin resistance in bone marrow transplant recipients, and neonatal hypoglycemia. It's quite interesting topics. And he is the author of a medical textbook on Noonan syndrome. He served as the senior editorial board member of multiple journals. And he also serves as a board member of a non-profit Human Growth Foundation. The floor is yours, Dr. Bhangoo. I'm sure we will hear your experience about Noonan syndrome, and it will blow our minds. Thank you.
Thank you so much for your kind introduction. So can I share the screen? Can you see my screen well?
Yes, doctor.
Okay, thank you. The topic of my presentation is on Noonan syndrome and how growth is in relation to the genotype. And then we'll just look at the malignancy risk with rasopathies also. So the learning objective of the talk is to discuss the clinical features of Noonan syndrome, the various genetic mutations which affect growth, and we'll also shortly talk about some cases and what genetic mutation they have, and short stature in Noonan syndrome and long-term data with growth hormone therapy, and also malignancy risks. So Noonan syndrome was originally described in the late 1800s by a physician in Latvia, Dr. Kobylinski, and it was described as a wing-like extension of the neck. But it was not really that prominent syndrome until 1960s when it was described by Dr. Noonan, who was a pediatric cardiologist, and she had a cohort of children with pulmonic valve stenosis that she's described a syndrome of short stature and other features. So the estimated incidence of the syndrome is could be as close to 1 in 1,000 to 1 in 2,500 live births. But there's not been any population-based studies on this. Male to female is about the same, and it's autosomal dominant in 1/3 of the children, in de novo in about 2/3. There is some degree of familial occurrence also reported, and these are the various studies which have reported around 10% to 22% can occur in families. But to note, most of them are new mutations. And also there is an increase of prevalence of Noonan syndrome with increase of the father's age. There is a form of Noonan syndrome which is autosomal recessive, but it is not that common. So the diagnosis of Noonan syndrome is a clinical diagnosis. So in this syndrome, you would have short stature in the child, which is present in about 80% of children. Cardiac defects are present in about 90% of children. Most commonly, when you think about Noonan syndrome, you are going to think about pulmonic valve stenosis. But in about 20%, you can also have hypertrophic obstructive cardiomyopathy, along with the presence of ASD also is seen in about 5 to 10%. And there's some children with Noonan syndrome who do not have a cardiac defect, but it's not that common. Chest deformities are also overwhelmingly present in Noonan syndrome, and these include both the pectus carinatum and the excavatum. Cubitus valgus is present in 50%, and they do have some typical facial features as shown in the pictures over here. So when the child is born in infancy, you see the presence of hypertelorism, There is a midfacial hypoplasia. There is some frontal bossing, but you will notice over here the anterior hairline is actually quite far, and it's shown in the profile over here. The posterior hairline is also pushed down, and that's because of the presence of lymphedema that the scalp gets retracted back. And there is increased philtrum. So there are low set ears, so there are some subtle features that you can see in infancy. But the unique thing about the syndrome is as the child gets older, the facial features change. So when the children go into this pre-pubertal age group, that's where you see the typical triangular and face development. The ears are also low set. The anterior hairline is pushed backwards. There is hypertelorism, but also this presence of curly hair starts in this age group, which is not present before. And I haven't shown all the pictures, but as they go through puberty and as they become adults, the facial features continue to change. So that's a unique thing about the facial features in Noonan syndrome, that they change. And a significant amount of them also have bleeding or coagulation abnormalities, and that's about 30 to 40%. Could be factor 8, factor 11. There could be thrombocytopenia. There could be deficiency of von Willebrand factor. Peripheral edema is also present. And in males, there is a 70% chance of having cryptorchidism, which is also a significant feature of the syndrome. So other clinical features associated with poor feeding, failure to thrive. There's eye findings also that you can see in this, and also in severe cases you can see seizures, Chiari-1 malformations. Their joints tend to be hypermobile. There is an element of delayed puberty, and that's why I will show on the growth chart how they keep on growing till about almost like 19 or 20 years of age. And renal abnormalities have been described in 11%, so you should do ultrasound on every case. And also there's increases for certain tumors. I included this slide for neurological features because we don't want to think about Noonan syndrome as something to do with heart and the stature. A significant number of patients also have lower IQ, and they could be up to 23%. They could have poor tone, delayed developmental milestone. They have deficits in visual perception. Speech is delayed. It could be very severe. They could have autism spectrum disorder, and they also suffer from ADHD type features as well. So what are the various genetic mutations? So the mutations which involve Noonan syndrome are present in pretty much every cell needs these factors for cell growth. And if you have mutation in this pathway, which is called RAP-MAP kinase pathway, you will have all these abnormalities. And the mutations which involve Noonan syndrome are hyperactive or overstimulating mutations of this pathway. And this could be any pathway regulators, which is the PTPN11, which is the most common mutation seen in Noonan syndrome, and also SOS1, NF1, SPREED1. So these are pathway regulators, and any mutation can cause either Noonan syndrome or Rasopathies. And the RAS protein by itself, which are KRAS, HRAS, NRAS, can cause mutations which present as Noonan syndrome. And then downstream from RAS, the MAC, the RAF, MAC, and ERK, and mutations have been described, which can affect and give you a phenotype of Noonan syndrome and Rasopathies. Classical Noonan syndrome is typically described in patients who have were found to have mutations in the PTPN11, SOS1, RAF, and KRAS, and you can see these tend to be mutations which are a little bit early on in this pathway. So if there's mutation early on in this pathway, they tend to present or with the classical Noonan syndrome, if you have mutations downstream of the pathway, so, the clinical features, they do change. So what's the mechanism of short stature in Noonan syndrome? Why does it affect, why stature is affected in this syndrome? And it is shown that in about half of them, mostly in the PTP111 mutation patients, there is an element of growth hormone resistance. And this was shown in studies which showed that there is low IGF-1, there is low low ALS, and a normal IGF-BP3 protein, which is usually seen in growth hormone resistance. So it was thought that growth hormone resistance could be a reason for short stature in Noonan syndrome. However, growth hormone deficiency is also being reported, and I also see that in a clinical practice. And this was based on the stimulation test. There is also an element of neurosecretory dysfunction, which is basically low levels of growth hormone secretion overnight, and the pulses are also not normal. So these children, even though when you do a stimulation test, you will get a good growth hormone response, but in actuality, they are not normally producing and secreting growth hormone. That is also seen in Noonan syndrome as well. So we are going to briefly discuss what is the natural history of growth in Noonan syndrome without the growth hormone therapy, and then we'll look at growth hormone therapy and how that changes. So if you typically look at a child with Noonan syndrome, the height starts to drop off by the first year of life. And in majority of them, before puberty is going to start, they are below the third percentile already. And during puberty, the height gets even more severe and can get to a negative 2.5 below the mean. And that has to do with the fact that puberty is late in Noonan syndrome. And during puberty, if you compare it with other children, their height, it looks even more severely affected. So this is typically seen in a girl who's around 11 and after 12 years of age in a male. Again, males, you will see in the growth chart, don't really have a plateau. They just keep on slowly growing till a later age and can continue to even in some cases grow beyond 20 years of age. So this was the first sort of charts which were prepared for Noonan syndrome in the Netherlands in the 1980s. And this is transposed on the regular growth chart, which is the shaded, and the lines represent the 50th percentile and one standard deviation on each side for Noonan syndrome patients. And you can see in the boys, you see how these lines are just keep on going up, and there is no plateau in the height as you see when children normally go through puberty, and after that closure of epiphys, then they stop growing. You can see a little bit of a plateau in the girls, and that could be because of the effects of the estrogen on the growth plate. But anyhow, even in the one standard deviation above the mean, these children are barely getting into the normal growth charts for regular population, and this is for both boys and girls. That data was followed by another set of growth charts, which was created in Germany by Renke, and also very similar representation, which is shown over here on the left side of the slide by dots, which are basically every child with Noonan syndrome was plotted for boys and girls. And as you can see, very similar to the data from Netherlands. But this paper was good also because it gave bone age data, and bone age tends to be a little bit delayed in this, but it doesn't start off to be delayed from the beginning, but as the children are growing, and you can see in this middle section of the slide, chronological age, and then bone age starts to be behind by 2 to 3 years. And as they are going through puberty, you would see that bone age would be more delayed. On the right side of the slide is the representation on the dots. It's very small, but what you could see is the males with Noonan syndrome tend to have lower growth velocities through their life, and also they have a pubertal growth spurt but the pubertal growth spurt is also very small, as it's actually less than the 1 standard deviation for a normal male, but they keep on growing a little bit longer. Something very similar in females also, the growth velocity is slower than average. There is a very small pubertal growth spurt, and they keep growing longer. So the growth spurt also during puberty is very small, and so these children will not be able to catch up with their height even during puberty. Again, this is from the same data. It gave us normal growth velocity for a child with Noonan syndrome, and males and females are represented over here. And in the red outlined box, you can see the growth velocities of male and female. So they start off by around 9 centimeters per year in the second year of life, but then the growth velocity really slows down to suboptimal growth right, in the pre-pubertal, and during they can go as low as 3 or close to 4 centimeters per year, and during puberty, also the maximum growth velocity for a boy would be 5, and for a girl would be 4 centimeters per year. So again, showing the same data that they really don't go through a pubertal growth spurt. Also, final height was given in this paper. Final height for a male with Noonan syndrome would be roughly around 161 centimeter, and female would be around 151 centimeter. So then different papers from different countries showed the final height. Mostly it was around, from the European cohort, 161, 162 for males, around 151 for females. But this paper from the UK showed that the final height of males were 167, which is usually higher than what we know now. So it's typically around 161, 162 centimeters is the final height. And then there is a Japanese paper which showed heights, which is shown over here, and there's a Brazilian cohort. So there could be national variation in their final height in Noonan syndrome. So let's talk about the PTBN11 mutations, which is the most common reason of Noonan syndrome, approximately half of them. And also, among the PTBN11 mutations, around 70% are going to have short stature. And so the PTB111 is your typical Noonan syndrome. When you think about Noonan syndrome, that is because of the PTBN11 mutation. And the height standard deviation for them is around negative 3.5 on average. And these are the children who would have the pulmonic valve stenosis, and they are less likely to have the hypertrophic cardiomyopathy. Some patients could have, but typically they have a pulmonic valve stenosis. There could be an AST also. And they tend to have more of a bleeding disorder, and there is also a slight risk for leukemia, especially JMML and MET. So the growth in a PTBN11 mutation starts to be slow from the very beginning. The mean birth length is within the normal range. However, it is on the lower side of the normal range. So these babies are on the smaller side when they're born, and after that, they start to be shorter, especially by about 2 years of age, significantly shorter, especially if you compare them with the SOS1 mutation and other conditions which are affected by PTBN11. The PTBN11 mutations tend to be shorter, and there is an element of growth hormone resistance, especially in the slides that we have seen, and also the final adult height versus other types of Noonan syndrome in PTBN11 is more affected. So this is the patient, one of the patients that I see in my clinics is now 8 years old, has a PTBN11 mutation, initially presented with short stature, roughly around 2.8 standard deviation. He was treated with growth hormone therapy, but the growth hormone therapy initially was not a higher dose, was a 0.025 milligram per kilogram per week, which roughly is around 40 micrograms per day. kilograms per day, and then was lost to follow-up during COVID, and then came back to our clinic. And we started treating him with higher dose of growth hormone, and he has since responded well. Apart from that, this child has very severe speech delay, cannot speak at 8 years of age, just makes sounds to communicate, has very severe sensorineural hearing loss, also has a severe pulmonic valve stenosis, ASD. He was diagnosed with autism spectrum disorder, ADHD, and oppositional behavior, and is currently getting speech therapy, occupational therapy, physical therapy, and other therapies to help, but still very severe delay. On the other hand, I'm also taking care of a 14-year-old male who also has a PTPN11 mutation, and mother also has Noonan syndrome. So this is an autosomal dominant form of Noonan syndrome that he has, but his height is not severely affected. And also his mother was able to get to a height of 155 centimeters without getting any treatment. And he also refuses growth hormone therapy. He says that his height is normal and he does not want to be treated with growth hormone. And his height used to be actually in very good range. But as you can see, as we compare him with the regular charts in the pubertal age group, his height keeps on going down and down because he really has not started puberty. He's really very big in the beginning as far as his testicular volume. Also, he has a history of orchiopexy, and we are still not able to palpate one testes. So there is an element of pubertal delay along with the history of orchiopexy in the past. He also suffers from behavioral issues and has been recently diagnosed with autism spectrum disorder, and also has a very severe failure to gain weight, and is still at 14 years of age and on a G2. So he has also a severe phenotype, but the height is not affected to that extent. And also, interestingly, his cardiac profile has also been normal. He does not suffer from a severe cardiac defect as well. Then the other common mutation seen in Noonan syndrome is called the SOS1, which is present in about 10 to 20% of patients, and around only 35% of patients with SOS1 have short stature, and their height tends to be a little bit on the close to the normal side of the normal range, low side of the normal range, and they still have the pulmonary stenosis phenotype part, but again, not that frequent, just like that. Deficiency is not. And they have clearly normal intelligence. They can even have intelligence. They tend to have this pea hair, and also they have pigmentation issues. With SOS1 mutations, they have higher chances of developing these giant cell lesions, and also some malignant and benign tumors are reported. And I was taking care of this patient who was seen for Noonan syndrome, and his initial height was a negative 2.2, negative 2.3, standard deviation below the mean. We started him on growth hormone therapy for only about a year. And also around the same time, he started to have development of a lesion around his mandible, which was found that he has a giant cell granuloma on the mandible. Growth hormone therapy was immediately stopped. He started seeing an oral maxillofacial surgeon and was treated with intranasal calcitonin and denosumab. The size of the lesion did not grow further, however, it also did not regress. And the natural history of this lesion is that after puberty is finished, the size slowly grows down after puberty is finished. But as you can see on the growth chart, even without growth hormone therapy, this child continued to grow and was able to get into the 10th percentile, close to the 10th percentile for height. He is still growing, so his final height has not been achieved yet. You could still see the pulmonary stenosis that we talked, and the cryptorchidism was seen in him. He also had a Chiari-1 malformation, increased bruising, and he was also diagnosed with a juvenile xanthogranuloma, for which he is followed by oncology. So these lesions that look like this, and you have to be watchful for these lesions. and they do develop such lesions. These are usually not freckles or pigmentation changes. They're changes in the skin, and they need to be referred to an oncologist for follow-up. Then BRAF mutation, which is not only seen in Noonan syndrome, but also seen in Leopard syndrome and cardiofaciocutaneous syndromes. This presents with severe short stature, and even cases of growth hormone deficiency has been reported. But I think the most common feature of this is a very severe neurological phenotype. So they have neurocognitive impairment and regression, but around 15 to 50% of them can also have epilepsy and encephalopathy, and which is resistant to multiple medications. They can also have a phenotype of craniosynostosis, and cardiac phenotype is associated with pulmonic valve stenosis, and you don't see much of the cardiomyopathy in these cases. So this is a case of a 13-year-old girl that I'm taking care of, who also have a BRAF mutation, and she has very severe short stature. Her current height is still a -3 standard deviation even after treatment with growth hormone. But she also had a very significant history of craniosynostosis requiring multiple cranial wall remodeling and frontal orbital advancement surgeries. Interestingly, she does not have any cardiac lesion, but also has very severe failure to thrive, and during early childhood got oral feeding therapy, and also suffers from hearing loss. Interestingly, she has some insomnia, a difficulty to sleep, and also suffers from speech delay and eye issues for which she's seen by an ophthalmologist. So as you can see, all these children, not only they affect just stature and heart, but also has very severe developmental profile and needs to be seen by multiple specialists. NRAS mutation is an interesting one because it's usually a very mild phenotype. It's not very common reason for Noonan syndrome. And in some of the adults, they, as they grow up, they don't even have any Noonan type of features. And so when you see the parents, you say, oh, your parents don't have it, you probably have a de novo mutation. But what happens is during childhood, they had symptoms, and when the parents become adults, they lose some of the features. Same thing happens with the stature. Most of these individuals are able to have a normal height in the adult. And their cardiac phenotype can be normal, or they can have some other features like coarctation of aorta. They go through delayed puberty, but they do have ADHD learning deficits and visuospatial defects with the syndrome. So this is a 5-year-old child who comes to my clinic at least once a year, has an NRAS gene deletion, which is part of the 22 M base pair deletion that he suffers from. And he has short stature, but not significant. He's on the 8th percentile for the normal US CDC charts, which is a -1.4 standard deviation. He's not on growth hormone therapy. He's followed just for growth, but he does have a small PDA, but has a normal pulmonic valve. But he was followed by oncology for JMML surveillance. He also has issues with development. He has issues with his gait, and he has this periodic limb movement disorder and sleep issues, and also has some skin changes for which he's been followed. So, but overall, NRAS mutations will give you a mild phenotype, but they still have to see other specialists. I put RAF mutation over here because it's interesting, and it's present in about close to 10% of patients with Noonan syndrome. It's usually a de novo mutation. So this is the type of mutation which will give you very severe short stature. 85% of the RAF patients have severe short stature. And these are some of the mutations which have been noted on the slide to present with the severity of the stature. They do tend to have more skin issues, like more nevi, lentiginous, and cafe, all these parts. But the cardiac phenotype in RAF1 is not so much about the pulmonic valve stenosis. It is mostly about the cardiomyopathy. And there have been some cases of fatality reported in the very young age with RAF1 and cardiomyopathy in babies. And they also have higher chances of developing arrhythmias. And RIT1 mutation is another one which is presented with hypertrophic cardiomyopathy. However, it's also present in about 10% of Noonan syndrome. However, the stature phenotype is not that severe in RIT1 mutations. And this will be a type of Noonan syndrome which you would see mostly in the cardiology clinics and might not even get referred to the endocrinology clinic because their height phenotype is not that severe. But they do also have lymphatic system abnormalities along with their cardiac abnormalities. So what's the experience with growth hormone therapy? So experience with growth hormone therapy started even before the FDA approved the use of growth hormone in Noonan syndrome. And this was based on the observational studies which were published in the early 2000s and 2015. And small number of patients, somewhere from 16 to 29. But it showed that the height standard deviation at the beginning of the treatment was usually around a negative 2.9, 2.8. And it took many years. It took like 6 to 9 years of treatment. And the height could change by 1.3, 1.77 standard deviation, but it takes a long time for height to improve. And also the age of start of therapy is later, usually in Noonan syndrome. There are some children who were started at 11 years of age, which is late for a successful outcome from growth hormone therapy. This is data from growth hormone registries, and right through 1990s to the 2000, close to 2019. And these are the data that we can have a large number of patients, but it is very similar to the data which was seen in observational studies, but also showed that mean height standard deviation was even more severe now when you collect more data, up to a negative 3.5 standard deviation. And with about 3 to 4 or 3 to 5 years of treatment, there was some improvement in height, but it takes again, the message is that it takes a long time for the height to improve in Noonan syndrome over many years. How is the growth velocity? The growth velocity in Noonan syndrome treated with growth hormone definitely improves from the baseline, which is roughly around a mid 4 centimeters per year. And in first year, it could be as good as 8.5 centimeters per year. However, you can see some studies show the second year growth velocity and the third year growth velocity significantly slows down. So ANSWER registry also showed similar. This had 120 patients with Noonan syndrome. Mean start of growth hormone therapy was at 9 years of age. Baseline height was a negative 2.6, but after 4 years of therapy, it did improve to a negative 1.3. But you can also see that the dose of growth hormone therapy in the beginning, in both the dosage that we are used to looking at, was on the lower side, and then by year 4, it was increased to a higher dosing of growth hormone therapy, and that's how we were able to achieve an improvement in the height outcomes. Nordinet had 30 patients with Noonan syndrome, and average age of starting growth hormone therapy was around 8 years of age. Very similar results, and it took 4 years for some significant improvement in height to happen. Then a very long-term data with growth hormone therapy was published by Ranke and from the KICS data, and it showed the graph on the left shows pre-treatment, and then after treatment, you can see the heights of the individual who were treated. They are clustered around the average for Noonan syndrome and around the 1 standard deviation of the normal height. But there are still individuals who are not able to respond to growth hormone therapy well. Something very similar, which is seen in males, the height is significantly affected before treatment is given, and then it improves, and the spread is a little bit more wide, and you can see some patients have not responded to growth hormone therapy as well. How is it with the different mutations? So this one is from a study which compared the PTPN11 mutation, which is the most common form of genetic cause of Noonan syndrome, and it showed that roughly around the height is roughly around a negative 3.0 before treatment, and after 4 years of treatment with growth hormone, the ones without the PTPN11 mutations, they tend to do a slightly better than the ones with the PTPN11 mutation. However, was not that much of a difference, but you can see the ones with the PTPN11 mutation do not respond that well to growth hormone treatment. This is our own, in our clinic, experience with growth hormone therapy in Noonan syndrome, and the height standard deviation, we looked at 5-year data, also took a long time to improve, started off with a negative 2.4 standard deviation on the regular chart, and it improved to a negative 1.6. We are collecting more data around a 7-year data of treatment with Noonan syndrome. And again, there was an increase in growth velocity, but by year 4, the growth velocity had slowed down to pretty much close to the pre-treatment height velocity. Adverse effects of growth hormone therapy. Growth hormone therapy is usually well tolerated in children with Noonan syndrome. However, if they have cardiac defects, especially the ones which are not pulmonic valve stenosis, but which are the hypertrophic cardiomyopathy, those are the ones that you have to be careful with. And these are usually the ones with the RAF1 and the RIT1 mutations. And data has shown that 3 out of 65 increased the hypertrophy and supravalvular aortic stenosis after treatment with growth hormone. One of the 14 in one study showed hypertrophy with growth hormone therapy, and this was a RAF1 mutation. But overall, the NCGS and the KICS data have shown that growth hormone is safe for cardiomyopathy. And usually it is recommended that once they are started on growth hormone therapy, of course, there should be a baseline echocardiogram and cardiology evaluation, but after starting, they should get an echo in 6 months to 12 months. And then once they've gotten to about 5 and 10 years of age, then they should also be getting echocardiogram. And this could change according to your institution. The studies here, they show that, there was no increase in the mean maximal left ventricular wall thickness during the study. And we have mentioned that 12 months of growth hormone therapy did not change features of hypertrophic cardiomyopathy. The other study over here showed that after 19, one of the children had developed hypertrophic obstructive cardiomyopathy, but there was no significant difference found in the LV dimensions between the baseline and 4 years of treatment. So overall, it's safe to use it in cardiomyopathy, but has to be followed very closely. Then moving on to the next section of the talk, which is to do with their malignancy risk. And why is that? That is because these genes are important in cell growth, cell function. So if you have a overactivating mutation in the cells, you would imagine that it would give increase in cell growth also. And in most of the somatic mutations, not germline mutation, which affect syndromes like Noonan syndrome or cardiofacial syndromes, somatic mutations are responsible for most of the cancers. Somatic mutations in this pathway are responsible for most of the cancer. However, not so much in germline, but still in germline mutations, you do see some increased tendency for cell growth. So certain PTPN11 mutations have been implicated in myeloproliferation, bone marrow disorders. There is a Noonan syndrome-like gene which is caused by CBL, which causes JML, and also with RAS, there is increased risk for leukemia or leukomyogenesis. So to be precise, with the malignancy risk with the PTPN11 mutation, one study showed that overall in life, cumulative risk for malignancy was 3.5 times in the general population. And as the individual is growing older, around 23% of the individuals are going to have some type of tumor growth or malignancy by the age of 55 years. There have been cases of PTPN11 mutation and post-growth hormone. Some tumor have been identified, and also there was tumors with metastasis also identified. There has been mutations which has been linked with the formation of JMML with the PTPN11, and this mutation is listed over here. And in general, the NRAS and the KRAS mutations cause JMML. And RIT1 gene mutations have been seen with ALL, but most of these are by age. When they happen by age 5. SOS1 has been, as we saw, it can cause benign lesions, but it also has been shown that in embryonal rhabdomyosarcoma and also in Sertoli cell tumors have been reported with SOS1. And giant cell tumors have been reported with PTPN11, SOS1, and RAF1. And LZTR1 gene has been associated with astrocytoma and malignant schwannomas. CBL, which is the Noonan-like syndrome, has been associated with JMML. So cancer surveillance is currently only recommended, at least according to this paper, for some specific PTPN11 mutations or KRAS mutations. And it is listed that they need a physical examination, CBC, every 3 to 6 months until 5 years of age, and same thing for the CBL. And as you can see, if you have other mutations, there is no special surveillance required, even though there has been links with some tumor formations, but still no surveillance has been recommended if you have other mutations. I also put NRAS mutations in the same category as KRAS mutations because they're very similar and they also require a GMML follow-up for the first 5 years of life. Future treatment in this could be a possibility of using MEK inhibitor, which has already been used in a NF1 patient who had an inoperable plexiform neurofibromas, and this can also be then used for other rasopathies, which will not only improve their stature but also improve some of their other phenotype. So these are the compounds which are still in the pharmaceutical pipeline in clinical development that they are used, but they have not really made it into the clinical field of clinical trials. So to conclude the talk, the height could be very variable. It could be anywhere from a normal height to a -5 standard deviation. And the height phenotype depends on some degree to the gene, but usually there is no genotype link, as you've seen some patient PTPN11 animal height. Most affected, if you have to particularly, would be the PTP and the BRAF1 mutation. And the least affected would BOS1 and RIT1 mutations. There is a gain in height standard deviation with growth hormone therapy, but as you have seen, this is usually very slow, and the best responses in the first year of growth hormone. And the correlations with the first year growth is the height at the start of growth hormone therapy and the growth hormone dose. And this is true not only for Noonan syndrome, but other conditions which are treated with growth hormone therapy. And cancer surveillance is recommended until 5 years of age for certain PTPN11 mutations, CBL, KRAS, NRAS are put in that category as well. Overall cancer risk in Noonan syndrome is low, but however, it should be discussed with every patient before starting growth hormone therapy. And with that, I would conclude my talk and open to questions.
Thank you, Dr. Banjo, for your talk. I think because we're short in time, we will skip the question part for now, but if there are any questions, we will refer them to you via email. Because we're short a little bit in time, we will head to our next speaker, Dr. Anurag Bajpai, MD, FRACP, SCE, consultant of pediatric and adolescent endocrinology.
Jasmine, excuse me, please. The next one is Khalid Haqqi, but Anurag will come next. So we will, I'm sorry. Sorry. Okay.
Tawfiq, I can go last if you like. If the lady wants to have the bone first, then I can go last.
No. Okay, go ahead. Okay.